Okay, so in the last video, we finished up discussing migraines and headaches and all that, right? And we stopped here, where we're now going to be looking at a laundry list of vocabulary words for movement disorders, and this is going to be significant for the neurodegenerative disorders that are going to follow on the next page, like Huntington, Alzheimer's, and Parkinson, and the others. So these words are, again, like we saw in dermatology, there were a list of words that you had to know to be able to describe what you see on someone's skin, right? Here we're looking at words that you would use to describe disorders in motion. I couldn't do the NBME thing. I was supposed to do NBME revision stuff today, but my Wi-Fi didn't exactly work with me, and a lot of shit happened, and I'm still really frustrated about it. But I couldn't do it, so I'm going to do it tomorrow at noon now. I had to reschedule it, unfortunately. Sorry about that. Alright. So, akathisia. Restlessness, an intense urge to move. Now, just like in dermatology, where certain descriptions of rashes and stuff were related to specific pathologies, there's stuff like that here too. So you can see how akathisia, right? You can see this as can be seen with neuroleptic use or as a side effect of Parkinson treatment. It's not directly related to Parkinson itself, but rather the treatment of Parkinson, right? So restlessness and an intense urge to move. Asterixis is also something directly related to many things. We saw asterixis first when we were in biochemistry discussing cases of hyperammonemia, right, when you have high amounts of ammonium. So extension of wrist causes a flapping tremor. This is associated with hepatic encephalopathy, which is directly related to hyperammonemia, Wilson disease with the copper storage, and many other metabolic derangements, mainly anything where you might end up having high amounts of ammonium. Or low amounts of GABA, right? In hyperammonemia, remember that you use up all your glutamate, so you end up not being able to make GABA. Athetosis is directly related to Huntington. So if you ever have a question describing a slow, snake-like writhing movement, especially in the fingers, that's athetosis. That's related to the basal ganglia, and this is going to be something related to to patients with Huntington disease. The same goes for chorea as well. Again, the basal ganglia. Chorea is the dancing, right? Like choreography. So chorea is related to dancing. Seen in Huntington disease and in acute rheumatic fever, known as Sydenham's chorea, right? So this is something I've seen questions on, where remember that Sydenham's chorea was one of the Jones criteria stuff. This is where a little child might present with chorea, and that child does not have Huntington disease. The reason it's happening is because there's a molecular mimicry in chorea as well, where the rheumatic fever stuff ends up getting deposited in the basal ganglia, right? So they end up having Sydenham chorea. Sudden jerky, purposeless movements is just happening, and they can't really control it. Dystonia is basically a lack of tone in a sense. So sustained involuntary muscle contraction, right? So dystonia is anyone who has like a stiff contraction, something like that. They can't undo it. So this is seen with writer's cramp, which really can happen to anyone. Blepharospasms, torticollis, again, another thing that can happen to anyone. Torticollis is related to your the neck. When you turn it, the sternocleidomastoid, it gets stiff and it won't stop contracting, and it hurts to kind of like stretch it out, right? So turning your head the other way is going to hurt too much. An essential tremor is a high frequency tremor with sustained posture, right? So anytime you have any kind of sustained posture, you end up having a high frequency tremor you can't control. And it gets even worse with movement or when you're anxious, right? So it's an essential tremor. This is different from an intention tremor, and you have to make sure you know that. Essential tremor is often familial. Patients often self-medicate with alcohol, which decreases the tremor amplitude. Treatment is to use non-selective beta blockers like propranolol or primidone, right? So primidone is a really interesting medication because that's really not one you see ever again in the book or anywhere else. So primidone is an anticonvulsant, according to Google, and it can treat seizure disorders. But you're not going to see primidone anywhere else except for on this page, and I've really never seen it being mentioned in a question, but NBME likes picking on silly things like that, right? So knowing that is pretty nice. So primidone for essential tremor. Also, something you could think of is think of essential tremor as like primary tremor, and the primidone has PRIM in it as well, like primary. So that's one way you could try to memorize that, but not exactly a high-yield thing, so don't worry about it too much. But compare essential tremor to an intention tremor. An intention tremor is a slow zigzag motion when pointing or extending toward a target. An intention tremor does not have anything to do with movement or anxiousness, right? But you see how essential tremor was related to a sustained posture. You end up getting a high frequency tremor with a sustained posture. An intention tremor is really going to be when you're trying to extend toward a target, right? Pointing toward something. Maybe you're trying to reach out to grab a remote, for example. That's another moment that can happen. And intention tremors are related to cerebellar dysfunction. Intention tremor patients will not try to self-medicate with alcohol because alcohol will not actually lower the tremor of their the tremor amplitude, right? So it will not lower the amplitude of their tremor. Myoclonus is a sudden, brief, uncontrolled muscle contraction. Right, so myo for muscle, clonus, just like tonic-clonic. Right, so myoclonus, sudden, brief, uncontrolled muscle contraction. So jerks, hiccups, common in metabolic abnormalities such as renal and liver failure. So not really going to be related specifically to one of your neurodegenerative disorders. The last thing, so we saw essential tremor, we saw intention tremor. The last thing here is a resting tremor. This one is, there's 3 different types of tremors, and you should be able to differentiate between all of them really, really well. So a resting tremor is uncontrolled movement of distal appendages. Tremor alleviated by intentional movement. So this tremor is really only occurring when you're not moving. As soon as you start doing something, the tremor goes away. Okay, so occurs at rest, called the pill rolling tremor of Parkinson disease. Right, so resting tremor is going to be related to Parkinson. Intention tremor, really just cerebellar dysfunction, is not related to one specific neurodegenerative disorder. And essential tremors, again, they're just familial, not related to one specific neurodegenerative disorder. But a resting tremor is definitely going to be related to Parkinson, and when you park your car, it is at rest, is one way to think about it. The last thing is restless legs syndrome. So this is worse at nighttime and at rest. It's relieved by movement. Restless leg syndrome occurs to a lot of people. It's not exactly the worst thing on earth, but if it occurs at rest or nighttime, this can be a problem because if you're sleeping with someone, if you have a spouse you sleep with, then your restless legs can definitely keep them awake. Associated with iron deficiency and chronic kidney disease. I've never really seen a question where this association was tested though. And treatment is to use dopamine agonists like pramipexole or ropinirole. UWorld had a little note that said, clinically described by an irresistible urge to move the legs and is usually accompanied by uncomfortable sensations that may be difficult to describe. The symptoms are worse at night and exacerbated by rest, relaxation, and falling asleep. So that's where the issue comes up. That's where the problem is. Now, the next page we're going to start seeing neurodegenerative disorders. And way in the beginning, I made this color-coded thing where you could kind of use this to really understand what do you call these? Man, word farts are the worst. Which one of these chemicals, whatever they are, hormones, are going to be high or low in specific neurodegenerative disorders, right? So we took each one of them, GABA, norepinephrine, acetylcholine, dopamine, and serotonin, and associated a specific characteristic to each one, right? So GABA is the inhibitory guy. So if you're missing GABA, you probably have a disease where you're unable to inhibit something. Norepinephrine is for activity, whereas acetylcholine was for rest, right? Sympathetic versus parasympathetic. Dopamine is your motor control and reward hormone, and serotonin is the peace and happiness hormone. So the way we applied it was that we looked at each one of these conditions and then made sense out of why any of these things would be low, right? And there was a table regarding this stuff in the beginning of neurology and physio. So just a quick revision, anxiety has low GABA, high norepinephrine, and low serotonin. And respectively, each one of those means that you cannot stop moving, right? Because you're going to be fidgeting like crazy. You have high activity, right? So high norepinephrine. And there's no serotonin, so there's no happiness. So you have depression, right? Something like that. That's kind of how you want to think of someone who does have chronic anxiety disorders, right? Because when you have nonstop anxiety, that's actually really, really bothersome and can actually be debilitating. You might not even be able to work correctly, right? So lack of inhibition, high activity. right? It's not going to really make sense if you have high amounts of both of these things, right? So that's another way to remember that. You're not going to have high GABA and high norepinephrine, because then you're going to be inhibiting all your own activity. So low GABA, high norepinephrine, low serotonin. Depression doesn't have high of anything. They have low dopamine, so there's no reward, right? They don't enjoy doing things that they actually like to do before. Norepinephrine is low because depression doesn't really let you go out and play sports. You're really just going to sit at home, right? So no activity. And then, of course, you have low serotonin because you're not happy. Schizophrenia has high dopamine, and that's all there is to it. Right, that's the only mainstay of schizophrenia, is to remember you have high dopamine, whereas the mainstay of Alzheimer's is that you have low acetylcholine because you lose the nucleus. Huntington and Parkinson tend to be the slightly more difficult ones to remember. Main thing is the GABA and serotonin that you want to make sure you get. Right, Parkinson is actually pretty depressing. Parkinson patients will never really be happy, so they have low serotonin. Huntington is also slightly depressing, but the main thing with Huntington is the fact that they can't stop moving, right? There's a lot of movement stuff related to Huntington. They cannot stop moving, so they have low GABA. There's no inhibition. As far as acetylcholine and dopamine is concerned, remember how you treat these guys to remember what's high or low. And acetylcholine and dopamine are actually at a checks and balances in your body, where if one guy is high, the other guy being low becomes a problem, right? So anytime you're out of dopamine, your acetylcholine is going to overpower everything, and vice versa. If you're out of acetylcholine, dopamine is going to overpower everything. And that's how you kind of see the symptoms you see in people. So you want to make sure you know these, because that's what's going to show up in questions when you get tested on these diseases. So now we can start taking a look at each one by one. So neurodegenerative disorders is a decrease in cognitive ability, memory, or function with intact consciousness. And this is pretty much true of all of them, right? And they love throwing in memory because they always love confusing people into thinking is something Alzheimer's or not. Must rule out depression as a cause of dementia, which is also known as pseudodementia. Other reversible causes of dementia are hypothyroidism, vitamin B12 deficiency, and neurosyphilis. So none of that can really be a part of stuff before you actually, diagnose someone with Parkinson, Huntington, or whatever. First one we have here is Parkinson's disease. So Parkinson's traps your body. So what is Parkinson's all about? You have a loss of dopaminergic neurons of the substantia nigra pars compacta. As long as you remember that, you're always going to remember Parkinson has low dopamine, right? Low dopamine. If you have low dopamine, you must have high acetylcholine. So what do you start seeing in these people? You get the pill-rolling tremor at rest, right? The resting tremor. Rigidity, mainly cogwheel rigidity. Akinesia. Postural instability, and a shuffling gait. This one is actually really clinically relevant too. So basically your patient will walk. When you ask them to walk, they won't be able to lift their feet up high. They're really just going to be dragging their feet, so walking while dragging your feet. And you can see all of these things if you YouTube Parkinson patients, right? If you try to see clinical relevances of Parkinson patients, you can see how Parkinson patients do all of these things. You can see the pill rolling tremor. You can see their cogwheel rigidity, the akinesia, any postural instability, and mainly the shuffling gait. MPTP is a contaminant in many illegal drugs, and that thing gets metabolized to MPP+, which is actually toxic to your substantia nigra. Right, so this would be relevant to someone who ended up having acute Parkinson disease, right? Acute Parkinson disease. Parkinson disease usually will not be acute at all, and sometimes there's going to be like a family history of Parkinson, but you're not going to see that here, right? So Parkinson disease, usually will be something that occurs after a long period of time. It's really not acute. It just happens slowly, very, very slowly. Neurodegeneration occurs, your substantia nigra disappears, and now you have full-blown Parkinson. But if the patient also does drugs, right? In almost every question, when you do URL questions, you see it, right? This patient does not smoke, drink, or do drugs. If they tell you that the patient does drugs and the patient looks pretty young and they're having symptoms of Parkinson's, then you should start considering this if it's in the answer choice. You never really consider this unless it's in the answer choice. It's not something that'll come to your mind. But if you do see MPTP or MPP+ in your answer choices, then you want to go ahead and start thinking, all right, this is Parkinson because of an illegal drug this patient is doing. Lewy bodies are composed of alpha-synuclein, and that's kind of something you're going to see on histology in Parkinson patients. intracellular eosinophilic inclusions. So that's image A. Let's go take a look at that. Image A, right here. This pink, right, so eosinophilic, this pink thing that you're seeing in image A, right, and you know image A is showing you neurons and stuff is coming from the brain. That is a Lewy body right there. Okay, these are usually pretty easy to identify in a histological image of a Parkinson patient, because when you see it, you'll see the bright pink. Like this, there's never going to be anything else. You can see none of these other images have it. There's never really going to be anything else that's nice and round like that and pink. So that's a Lewy body. And that's something that once you see it, you can go ahead and consider Parkinson based off of whatever else is given in question stem. Next guy is Huntington. So Huntington is a lot more than what you've been seeing in the rest of the book so far. This is where they really tell you everything about it. And then there's an image from UWorld that tells you a lot more too. So Huntington disease is an autosomal dominant trinucleotide repeat expansion in the Huntington gene on chromosome 4. All of that is really easy to remember because you've probably seen it many times already. And the statement of you need a cage to hunt, that's another way to remember the CAG stuff. Right, so anticipation results from expansion of the CAG repeats, but the CAG is great. First of all, you need a cage to hunt, right? Or a cage for hunting is another way to remember it. Right, so like, let me just write it out. Cage for hunting, like that. So you can kind of remember the CAG, the chromosome 4, and Huntington. This is perfect because the CAG really reminds you of this. The caudate loses acetylcholine and GABA. So remember, we were trying to memorize this stuff for all of them. Huntington's probably the easiest one to remember after remembering the fact that, you know, schizophrenia is just high dopamine, Alzheimer is just low acetylcholine. Those two are the easiest. But for multiple things, Huntington and Parkinson are really easy to remember because Huntington you can just remember with this. You lose acetylcholine and you lose GABA. So if you lose acetylcholine, you must have high dopamine and that's it. Right? And if GABA was related to Huntington, then serotonin must be related to Parkinson because, of course, one of them had serotonin, the other had GABA. You have to kind of remember that part on your own. Right? So Parkinson has high acetylcholine, low dopamine because it's the opposite of Huntington, and it has low serotonin, whereas Huntington has low GABA. What else do we need to know? Symptoms manifest between ages 20 to 50, and you start seeing chorea, athetosis, aggression, depression, dementia, sometimes initially mistaken for substance abuse because the patient really starts acting weird. However, compared to Parkinson, the main thing with Huntington is it's autosomal dominant. So almost always you're going to get some kind of family history. You know, someone else in the family had similar symptoms at some point, maybe at an older age, and this patient might be exhibiting it at a younger age. So atrophy of the caudate in putamen with ex-vacuoventriculomegaly is something you'll see on gross findings. You're going to have high dopamine, low GABA, low acetylcholine, and the neuronal death will occur thanks to NMDA-R binding and glutamate excitotoxicity. Right? And that's something that you can get a pathophysiological question on. So neuronal death is due to NMDA-R binding and glutamate excitotoxicity. Now, there's an image here. Let me see. This one. Right, so this image is related to Huntington. It's really important to understand the pathophysiology, and UWorld teaches this. It's not in the first aid. So they tell you that transcriptional repression, which causes silencing, right? So that's going to be with methylation usually, but this is not methylation here. Watch what happens here. So this is a good question that they like asking you because everyone's going to say methylation. Transcriptional repression is one of the mechanisms by which mutated Huntington is thought to cause Huntington disease. Abnormal Huntington actually causes increased histone deacetylation, leading to silencing the genes necessary for neuronal survival. So there's a couple genes that you need to keep your brain healthy. You're going to end up muting those genes, but you're not muting them by methylation. You're muting them by removing the activation. You remove the acetylation, right? Acetylation is supposed to activate a gene. You remove the acetylation off the histones, right? You can see that the mutant Huntington is going to come over here, stop histone acetyltransferase. So you end up not being able to acetylate it. You're not going to be able to acetylate it. And histone deacetylase is going to overpower that. So you end up removing all the acetylase. And you see how it's loosely packed here? Now it becomes all tightly packed and you cannot do transcription. Decreased transcription of neurotrophic factors, right? Neurotrophic factors leading to impaired neuronal survival. So that's one of the pathophysiologies, and probably the main pathophysiology of how Huntington leads to neurodegenerative issues. Right? Histone deacetylation. Don't fall for histone methylation. That's not the correct answer. Although, it totally makes sense to think that way, but now you know what the correct answer is. So that's Huntington. Next big guy is Alzheimer's. Now, there's a bunch of pictures for Alzheimer's, B, C, D, and E. Most common cause of dementia in the elderly. Down syndrome patients have increased risk of developing Alzheimer's disease because the APP gene is located on chromosome 21, and Down syndrome patients have 3 copies of chromosome 21. The only thing that's affected here is you're going to have low acetylcholine. Right? There is a deficiency of acetylcholine acetyltransferase. Another little note related to something that was questioned about in an NBME. Associated with the following altered proteins. ApoE2 is going to be the one that's associated with decreased risk of the sporadic form. ApoE4 is associated with the increased risk of sporadic form. So I wrote over here 4 is more than 2, so 4 has more risk of sporadic form. That's pretty nice of a way to remember that. APP, presenilin 1 and 2, and familial, these 3 guys are all related to familial forms with earlier onset. So early onset Alzheimer's, usually you want to start thinking of these things. So presenilin, when you're senile, that means that you're old. Right? So pre-senile means that you're old before you actually should be old. So I like how they named whatever this protein is. Right? So presenilin. Now, what do you start seeing on gross and histological exam? Widespread cortical atrophy. Right, so now you're going to see, I'm going to show you images that first aid has, the normal cortex versus the cortex in Alzheimer's disease, images B and C. So this is your normal cortex, non-demented, and then look at C. And the red arrow is pointing at a specific part that's really depleted. Right? Especially the hippocampus, arrows in B and C. And that's what that red arrow is pointing at. So if you didn't know, and you should have known because we've been doing anatomy, we already did all of anatomy for the neurological section. That is your hippocampus. And you can see that in Alzheimer's dementia, you lose the hippocampus. Right? Slowly but surely, it all goes away. Narrowing of the gyri and widening of the sulci. This is just a really annoying little sentence that you just have to remember. Right? So narrow gyri and wide sulci. What else do you see? You're going to see senile plaques and neurofibrillary tangles. Senile plaques are in the gray matter. They are extracellular beta amyloid core, may cause amyloid angiopathy leading to intracranial hemorrhage. Right? A beta, amyloid beta, synthesized by cleaving the amyloid precursor protein APP. And you can see that Alzheimer's patients are going to make more APP than usual, which is why they'll have a lot of senile plaques. Neurofibrillary tangles are intracellular hyperphosphorylated tau protein. Right? Tau protein. This thing is insoluble cytoskeletal elements, leading to a lot of dementia. And the number of tangles correlates with the degree of dementia. Right? So if you have a lot of neurofibrillary tangles, then you're going to have a lot of dementia. If you don't have much of it, then the dementia is going to be pretty low. So D and E show you those things. So D right here is showing you the senile amyloid beta plaque. Right? And this is your histological image of your brain, mainly the cerebellar area here. E is showing you your neurofibrillary tangle. Okay, so anything that looks like this is your tangling that you're supposed to be focusing on. This image is really zoomed in, so it's kind of unfair in that aspect. Right? They're zooming in to really help you kind of see it. But what you should be doing when you see images like this is to Google more images of stuff like that, right? So when I go ahead and Google neurofibrillary tangles, this is what I see. So first thing, this thing is pretty nice. This image right here, I don't know if it'll show up big or not. This one, yeah, it does show up big. So here you're seeing like a really nice image on Wikipedia showing you the stabilizing tau molecules, right? So they're pointing those out, those things. That's your healthy neuron, right? In a healthy neuron, you have stabilizing tau molecules. Now look at the diseased neuron. This would be a patient with Alzheimer's. Here, you have disintegrating microtubules, and disintegrating microtubules are going to fall apart, right? And then you end up getting tangled clumps of those same tau proteins. So now you know where the tau came from, right? This is a really, really nice image that you would have never really seen if you didn't Google neurofibrillary tangles like I did, right? So I googled neurofibrillary tangle, and the first thing that showed up was this. And it's a really nice image. So now you can see that your tau proteins are actually your microtubule holding molecules, right? Those are tau molecules right there. They basically stabilize the microtubule formation. Without them, your entire thing just, all the beads are basically falling apart. That's kind of what it looks like, right? It's the string that's holding your beads together. When your beads fall apart, you get the neurodegenerative disorder, and then all the string is kind of sticking together and clumping up, and that's your tangled clumps of tau protein. Right, so really, really nice image in that aspect. The other thing is, looking at all of these, you can see what we're looking at, right? So you have your neurofibrillary tangles. That's what they look like. Right, you can find many images of it, neurofibrillary tangles. So the first 8 image was just really, really zoomed in onto one neurofibrillary tangle. So I wanted to show you a couple more, and that's something you should always be doing. So when you see images that are histological, make sure you Google more of them, right? For example, for image A over here, right? For image A over here, they told us that that's how a Lewy body looks like. So I'm going to go ahead and Google Lewy body Parkinson and go to images. So let's see what we see. So Lewy body, right? Lewy body Parkinson. You can see. Look at this image. This one is cool because this image, compared to what we have here, is a completely different stain. So that's always nice to do, right? Because you will not always have the same stain. So this image here is showing you a Lewy body too, which totally makes sense. It's still pink. It's nice and circular, perfectly round. That's exactly what we're seeing. I moved the book. And that's exactly what we're seeing here too, except completely different stain. All right. It's really important to make sure you Google images that are histological, because you can get different magnifications for sure, right? Different magnifications and different stains. So there's a lot of images using that other stain, Parkinson, as well as here they're saying Lewy body in an Alzheimer disease patient, and that's kind of something that can hurt you, right? Because what occurs is, the problem being is, you're gonna see Lewy body in many things. Like, there's also its own thing. There's Lewy body dementia. So don't let an image telling you about Lewy body alone, let you diagnose someone with Parkinson. Make sure there's something else in the question that can really help you pick Parkinson. If they haven't given you anything in the question at all for you to be able to pick Parkinson disease, and all they're talking about is Lewy bodies, it might be Lewy body dementia. It could even be Alzheimer, because there are going to be Lewy bodies here too. They're all neurodegenerative disorders. The book doesn't mention Lewy bodies in Alzheimer's, but I have actually seen it, and we're seeing it right here too. So it is something that can occur. It is something that can occur. You want to make sure you're ready for that. But generally speaking, Lewy body, you want to think of, anytime you see Lewy body, you want to think of Parkinson, right? Lewy body Parkinson, and then Lewy body dementia. We're going to get to that, right? Not really per se Alzheimer's. Other than that, all these other images we're looking at, you can see the same perfectly circular stuff, perfectly circular pink, right? When you start seeing that, that's basically your Lewy body, and Lewy body should remind you of Parkinson. Now, the other thing, next up we have is frontotemporal dementia. So we're going to do all the questions I have on the page. I'll come back to it. Let's just wrap up what's on the page first. So frontotemporal dementia. So that's pretty much pointing out parts of your brain right there, frontal and temporal. This is also, it used to be known as pig disease. I still call it pig disease sometimes, but I know that it's also called frontotemporal dementia because it's actually frontotemporal lobe degeneration. So remember, your frontal lobe is a lot about how you act and your behavior with people. So when you start losing your frontal lobe, you know early changes in personality and behavior, something that never occurs in anyone, right? People's personality doesn't per se really change unless they actively want it to, and behavior is not supposed to change much either after you've already become an adult. You can also see aphasia. Mainly it's going to be a Broca's aphasia, because that's in the lower part of your frontal lobe. But if you lose your temporal lobe, the upper part of your temporal lobe, you could get Wernicke's aphasia too. May have associated movement disorders like Parkinsonism. Right? So inclusions of hyperphosphorylated tau protein, just like you would see, right? Where is it? The hyperphosphorylated tau protein, just like you would see in Alzheimer's, and pig bodies, right? Round pig bodies. That's what this is here now. right? So hyperphosphorylated tau proteins here, they're calling it PIC bodies. This is something that was confusing to me the first time I was studying, and let me show you right here. So you see how this is your PIC body in image G for frontotemporal dementia, whereas E was showing you your neurofibrillary tangle, and they're both tau protein. So you want to be careful with that. Don't confuse tau protein to only be for Alzheimer's or only be for PIC disease. They're both tau, and we now know what the tau protein was, right? It's the thing that was holding those microtubules together. When it tangles up, it makes neurofibrillary tangles that you see in Alzheimer's, like this. But if it doesn't tangle up and it's just hyperphosphorylated and round, you're looking at something that looks a lot like a Lewy body, but it's black. It's not black just because of the stain alone. It's made of completely different things, all right? So a PIC body is the frontotemporal dementia stuff, and that's going to be a hyperphosphorylated tau protein, whereas a neurofibrillary tangle is tangles of that tau protein, right? So they're both still tau protein though, so that's something you want to keep in mind. Ubiquitinated TDP43 is another thing you can get as an acid choice, but I've never really seen that pop up. Alright, so ubiquitinated TDP43, this basically means when you ubiquitinate something, it's basically going to be sent to lysosomes for destruction, right? So you're destroying all your TDP43. The significance of TDP43, I never actually Googled or looked up or anything, but TDP, you just want to make sure if you do see it in a question stem, just make sure you associate it with frontotemporal dementia. This is obviously not something related to Huntington, Parkinson, or Alzheimer's. The last thing on this page is your Lewy body dementia. So what you see here are hallucinations, and I always liked this thing, the hallucinations, because this did work for me. It would help me remember that if the patient doesn't have hallucinations, then the Lewy body I'm seeing is not Lewy body dementia. Right? Remember, we just said that you can also see Lewy bodies where we first saw it here, Lewy bodies, right? In Parkinson. And Parkinson patients do not have hallucinations, right? So hallucinations is going to be the presence of any hallucinations is going to be the determining factor for you when you're reading questions between Lewy body dementia and the Parkinson disease. Right? So Parkinson also has Lewy bodies. They're alpha-synuclein. Same alpha-synuclein here too. But in Lewy body dementia, you see the Lewy bodies in the cortex. So the patient will have visual hallucinations, dementia with fluctuating cognition and alertness, REM sleep behavior disorder, and Parkinsonism. Right? So there is overlapping Parkinsonism, but as soon as you have hallucinations added too, it's Lewy body dementia, not just Parkinsonism. Called Lewy body dementia if cognitive and motor symptom onset occurred under 1 year difference, right? So both things occurred around the same amount of time. Otherwise considered dementia secondary to Parkinson's disease. So the difference between the two things is very much set in stone, but it's also very overlapping, right? So if you have dementia because of Parkinson, then remember in Parkinson, both things have an onset that take more than a year to occur, right? Things are going to occur so slowly over time that it's just degeneration, it's neurodegeneration. So that would be Parkinson's disease leading to dementia. So dementia is secondary to Parkinson. But if you have dementia, right, if you have cognitive and motor symptoms that occurred within the same maybe 6 to 7 months, that's actually Lewy body dementia. Okay, so called Lewy body dementia if the cognitive and motor symptoms onset occurs under 1 year apart. All right, if it took more than a year for everything to occur, and they didn't occur together that quickly, that's actually dementia secondary to Parkinson's disease. First aid, yes, that's definitely something I'm looking forward to after this. So this playlist, once I'm done with this playlist, that'll be the end of anything I want to talk about regarding step 1. I'll be done doing NBME questions by then too. And then the next thing is to start looking at CK stuff. I'm going to be doing first aid for CK and UWorld for CK, similarly to the videos I'm doing right now. So now we can take a look at the questions we have here. So first question on this page was this one right here for Alzheimer's. Now, with Alzheimer's, the age is always going to be a really good giveaway to help you determine what's wrong. And UWorld did a really good job with that here, right? They picked someone really, really old. So you have an 82-year-old woman. comes to the clinic due to memory loss. As soon as you read that, you think, okay, this is probably Alzheimer's. She's 82. She lives with her daughter, who reports her mother has had difficulty remembering conversations. So here what I'm thinking is, okay, she doesn't live alone, so she doesn't necessarily have excessive loneliness. She has her daughter with her. And the only issue is she's difficulty remembering conversations, which can definitely occur even with normal people who are young and don't have Alzheimer's. So, it's not so bad. The patient has also forgotten recent events, such as her grandson's birthday party last month. Again, another thing that can occur. I can forget someone's birthday party. You can forget someone's birthday. Stuff like that. Nothing's totally pathological so far, right? 2 years ago, she was forced to give up driving after repeatedly getting lost in her own neighborhood and being in an accident. That definitely still sounds like Alzheimer's. The patient still enjoys reminiscing about old times with friends and playing bingo at the church. So she's not depressed. She doesn't have any other mental disorders as far as I can see. The daughter now manages her finances and acts as her healthcare proxy. What would you find in her pathology? So now, since the question is asking what would I find in her pathology, I have to know what the pathology is. And from this question, all I'm seeing is Alzheimer's. And Alzheimer's, any of these things would be the correct answer, right? So senile plaques or neurofibrillary tangles. And these things, you don't want to search for this word in your answer choices or, this thing in your answer choices. It doesn't have to say that. Look, UWorld put neuritic plaques, which again is a senile plaque. For neurofibrillary tangles, again, they could just put hyperphosphorylated tau protein. They could put tangles of tau protein, tangled tau, anything. As long as it's still the correct answer, it is the correct answer. They don't have to call it what you're accustomed to hearing it by. Right? So they could also describe neuritic plaques. They could say cleaved amyloid precursor protein, right? Or amyloid beta from cleaved amyloid beta, right? Any of these things would be correct answer choices. They don't have to put senile plaques or neurofibrillary tangles. And it was very obvious she has Alzheimer's. It was like a giveaway question. There was nothing wrong. She doesn't have depression. She doesn't have any other issue. She just has Alzheimer's. And she's 82. This question down here, this one is related to the next page. So let's take a look at what the last two things are for neurodegenerative disorders, and then I'll look at that question. So next one they talk about is vascular dementia. So vascular dementia is pretty new. Result of multiple arterial infarcts and or chronic ischemia. You have a stepwise decline in cognitive ability with late onset memory impairment. This is the second most common cause of dementia in elderly. When we get to psychiatry, we're going to see the difference between dementia and whatever the other word was. Wow. Let me actually find that. Today has been a really, really bad morning for me. Not really feeling anything. This thing right here, delirium, right? When we get to psychiatry later on, we're going to see the difference between dementia versus delirium, and everything we're seeing so far has been dementia in neurology, right? Dementia, you want to make sure you remember that dementia is usually a very slow onset thing. The onset of symptoms is always going to be a really big deal. And when you get questions, don't overlook the fact that they tell you, oh, this occurred over 2 weeks, versus this is something that has been occurring over months to years. So when you see a patient coming in with, stepwise decline, this is when you want to start thinking of neurodegeneration, right? Not some kind of toxicity, not delirium, right? Delirium is going to be something that's usually a lot more acute, and we're going to see that when we do psychiatry. So for vascular dementia, the only way you can really diagnose it, you'll do an MRI or a CT, and you'll see multiple cortical and or subcortical infarcts, right? Infarcts, not just destruction, but actual bleeding, something that is pretty rare, right? So that's why it's called vascular dementia. This is dementia due to just vessels not working too well anymore. It's going to be someone that's really, really old. But this is going to be a really, really old patient whose issue is not just memory impairment, right? It's not just memory impairment. It's late onset memory impairment. But first they'll have the stepwise decline in actually understanding stuff, right? Compare that to this Alzheimer's patient we had here. She's still doing fine. She still enjoys reminiscing old times, whatever she can remember, and she still enjoys playing bingo at church. You know, she's doing just fine. There's just a lot of things she can't do anymore because her, new memory is not that good. She can't remember recent things, so that's going to be problematic, functionally disabling. Last thing here is something that's always been a giveaway question. I've never seen a Creutzfeldt-Jakob disease question that was hard or something that I couldn't diagnose from the question itself. Rapidly progressive, right? So you could tell the difference between slow onset or stepwise decline, whereas rapidly progressive dementia, right? Rapidly progressive dementia, weeks to months, with myoclonus and ataxia. Commonly see periodic sharp waves on EEG and high 14-3-3 protein in the CSF. This they can just describe by telling you that the protein in CSF is high. Right? They might just tell you that. They don't necessarily have to say 14-3-3, as long as they give you other information to help you understand Creutzfeldt-Jakob. So this is going to be a patient who's popping up with some kind of sudden onset, unnecessary, rapidly progressive dementia. Right, and when you look at the gross findings, the spongiform cortex is one of the major things. They don't have a picture of it, but let me see if I could find something. Spongiform cortex, because I know MBME really loves gross images, and yeah, there really isn't a good picture of a spongiform cortex. What is this showing you? Brain shrinkage and deterioration occurs rapidly. Right, and this is a brain section showing you spongiform pathology characteristic of Creutzfeldt-Jakob. The main thing is the big white vacuoles you're seeing. Right? And there's a couple images here showing you really, really big white vacuoles. Right, so this is your prion disease, which, again, prion is exactly what we're looking at with Creutzfeldt-Jakob. You have prions. Right? Prions, you're supposed to have this thing, if any, but it ends up becoming this thing. And this is going to be the beta-pleated sheet that's resistant to proteases. You can't break it down anymore. Most patients die within a year. And that's what we're going to see right now. We have this patient in AMBOSS right here. So a 53-year-old woman is brought to the physician by her husband for the evaluation of progressive memory loss during the past 2 weeks. Progressive memory loss. During the past 2 weeks, she has had problems getting dressed and finding her way back home after running errands. And she's not that old, right? She's not like the 82-year-old patient we had from UWorld. She hasn't even hit 60 yet. So 53-year-old patient with progressive memory loss. She has also had several episodes of jerky, repetitive, twitching movements that resolved spontaneously. She is oriented only to person and place, but not time. She follows commands and speaks fluently. She is unable to read and has difficulty recognizing objects, which the following is the most likely underlying cause of this patient's symptoms. So immediately, just by looking at each sentence they gave you, you can't really associate her symptoms with one specific disease. It's not that, it's not that clear. And then, when they tell you she's unable to read, that's something weird, right? Huntington patients can read. Parkinson patients can read. Alzheimer's patients can read. You don't forget how to read. They can read. So immediately those things disappear from your answer choices. You can't pick those anymore. It's not just going to be dementia. It's not going to be just delirium. It's none of that stuff. Her brain is just dying. That's why she can't read. And it's dying because she has Creutzfeldt-Jakob disease. All right. And that was really all there is. So this patient has Creutzfeldt-Jakob disease, which causes myoclonus. That was the main giveaway thing. And rapidly progressive dementia associated with aphasia and agnosis, or agnosia. Alzheimer memory loss is progressive, but hers had rapid progression within the last 2 weeks. Normal prion proteins are found on the surface of cortical neurons and are protective against free radicals. That's the PRPC thing. Misfolded prion proteins accumulate into plaques and cause neuronal cell death and spongiform encephalopathy, and your brain just dies. Okay, so that's kind of what's happening with Creutzfeldt-Jakob disease, and that's it. All right, in the next video, we'll go on into idiopathic intracranial hypertension and start looking at hydrocephalus, which is a really high-yield topic. I'll have a couple practice questions, and we'll really make sure we understand what's happening with the various MRIs we see. So now we're going to start seeing a lot more diseases that is related to neurology. Thanks a lot for joining, guys.